now the management of severe AS and cardiogenic shock. Wow.
Wow, indeed. It's a pleasure to be here. Marwan, thank you so much for having me, and the organizers of Houston Shock, another amazing meeting. So here are my disclosures. I think the real important disclosure here is that we're sort of walking into a bit of a data-free zone, not entirely data-free, but many of these cases feel like make your own adventure. And so everyone in the room, I think, is familiar with the statistics of aortic stenosis. At least this is what we were navigating by when we started TAVR 10, 12 years ago, and recognizing that the severe symptomatic patients represent the minority of patients with aortic stenosis, and certainly when you've got the overlay of ischemic heart disease, LV dysfunction, and severe aortic stenosis, you really have a setup for some pretty big problems in terms of hemodynamic decompensation. As interventionalists, and I'll concede that this is a character flaw for us, we try to simplify everything and distill it. We think about this in terms of pressure and volume and pressure and flow and resistance. And the reality is that maladaptive remodeling in aortic stenosis goes far beyond that to pulmonary hypertension and LVH reduction in coronary flow reserve and so forth. And so there is a pretty complex interplay of variables in the patient that comes in a little bit decompensated with a lot of aortic stenosis. And to take this one step further, flow parameters in the aorta, once blood is ejected from the LV, also varies greatly from patient to patient. We don't sort of think about this when we see that wire whipping around in the aortic root and, we're sort of in, past minute 10 trying to cross the valve. We sort of remark on the interesting flow patterns, but we don't fully acknowledge what the implication is. So this gets to the issue of AS, cardiogenic shock, and clinical equipoise. I think on a macro level, we can all agree that we don't know what exactly the right answer is. The problem is that for every individual patient on a micro level, we believe we know exactly what the answer is and how we should approach this case. And it usually comes right down to this, right? So medical therapies haven't really worked for these patients, often inadequate. Surgery appropriately deems these patients prohibitively high risk. And then the ball is in your court in terms of TAVR now versus, this magical thing that's going to happen after you medically stabilize and maybe BAV, maybe mechanical circulatory support. And in patients who are fairly advanced, you have to ask yourself, is it even possible to stabilize the shock beyond some improvement of numbers without definitive therapy for aortic stenosis? There is some recent data that I think are interesting and helps inform this decision for us. This was published very recently, linking STS TVT registries with CMS claims data and picking out the patients who present with cardiogenic shock in the setting of severe aortic stenosis, a smaller proportion of patients, about 4% in this data set, and comparing them with a comparably high-risk cohort that don't have cardiogenic shock. And you can see the numbers there, about 2,000 patients with cardiogenic shock undergoing TAVR. The median STS is 9.8, and 13,000 high-risk patients without cardiogenic shock, a very comparable STS score. The punchline, of course, is not, terribly surprising. The patients with cardiogenic shock and severe AS who undergo TAVR don't do as well. How well do they not do? 4 to 5-fold times not as well in terms of 30-day mortality and 365-day mortality. The other interesting thing here is that if you look at the 1-year mortality, there's no late catch-up for these patients who are high risk but don't have shock going into it. And so the observation was made, maybe this is all related to complications because these shock patients have a lot of complications on the front end, and maybe the late mortality is just sort of the lingering effects. Turns out that's not the case. If you look at the safe subgroup based on VARC2 criteria, the absence of 30-day major complications does not seem to improve things all that well for these patients. And this is sort of the central figure. The sicker you are in terms of cardiogenic shock, the worse you do. Again, not surprising, but it put numbers to it, right? Inotropes, pre-procedure mechanical assist, cardiac arrest, and CPB. Once you get to CPB, you're talking about a 40% chance of 30-day mortality. This is one of many checklists that we sort of go through. This was published in JAHA all of the things that we worry about for transfemoral TAVR, I would ask the question, maybe we should be objectively assessing these patients because we may find more than 4.1% or 6% or 5% of these patients who are hemodynamically sort of on the fence before we actually go into these cases. And so maybe they should join the sort of menagerie of considerations, vascular complication, conduction block, and so forth. So what can we do? How can we make this safer? Well, we can do BAV with Impella backup and support and TAVR later if the decision is to defer this. And this is an algorithm that was published recently, and certainly there's lots of nuance to this. You can balloon it, and then you can follow yourself with an Impella and use single access, or you can use 2 points of access and do a balloon aortic valvuloplasty and Impella side by side. And then if you've got further decompensation or oxygenation issues, then you can sort of pivot and add ECMO and go a couple of different ways. What about if you want to proceed with TAVR now and say that things are just not getting worse, or there's a compelling reason why we can't wait BAV, temporize, and so forth? A number of different options here. And one interesting option is biatrial drainage with a vented venous cannula across the interatrial septum, drain both atria, oxygenate, and pump back. And so that's a consideration for these patients. Let me just close in the last couple of minutes with an interesting case which I think highlights many of the challenges of operationalizing some of these ideas. It's great to have slides and say do this or do that, algorithm, et cetera. I think a lot of these decisions are sort of fly by the seat of your pants. So this is a relatively young woman, but with a lot of medical issues. And you can see that her STS score is 12.5%, morbidity or mortality about 46%. Morbidly obese, some LV dysfunction, multiple stents, NASH cirrhosis, on and on and on. TAVR CT didn't really reveal any red flags. Everything looks good. And her area maps out to a nominal 23 implant. This is her angiogram from the outside. She had IFR-guided stenting of the circ, multiple prior stents in preparation for TAVR. And this is certainly something where reasonable people could disagree about whether stenting the circ is going to substantially improve outcomes in TAVR, but I think large vessels, we still tend to do this. This becomes important later. So going into her, TAVR, this is maybe a few weeks before, going into TAVR, she's been having some increasing chest pain and some shortness of breath. ECG's unremarkable, and we didn't do a real detailed hemodynamic evaluation because nominally she's normotensive coming in from home, complaining of some additional symptoms and so forth. In the OR, in the hybrid OR, big sheath on the right, small sheaths on the left, and anticoagulated, we take an aortic root injection, and then profound hypotension is noted, as you can see here, and we quickly run the list. It was dramatic enough that the CRNA said, I think the A-line kinked. I'm like, I don't think the A-line kinked. I think that's a real pressure. And so, we sort of run the list of things that might have happened, and as it turns out, this is what happened. You can see a complete occlusion of the left main. There's thrombus pretty much everywhere. Still not entirely sure what the genesis of this was because we're fully anticoagulated, but I suspect it has to do with the fact that she stopped all of her medications a week before in anticipation of the TAVR, including the prasugrel, and occluded the circ back. There was a brief period of time where I sort of wondered, could we get through this and just open up the left main and then just keep going? It was pretty obvious that we couldn't. You could see that she's intermittently VFing in the second image. So crashed to ECMO. 17:25, didn't bother to get antegrade access and just got to work with the left main, got everything open. And we saw in real time the circ occluding all the way back to the left main. We'd open it up, it would occlude, come back to the left main, shut down the left main. So we saw that. We played that game a few times until we finally got it to stay open. And so then the question is, what do we do? Do we just keep going here? We've got this open, we've got her on pump, we've got a map of 100. Do we wean the ECMO, recover the patient, delay the TAVR? Because she's sustained a significant hit in terms of ischemic injury at this point. We had this notion that maybe we'd take her to the CCU, we'd rapidly wean the ECMO or do our very best to wean the ECMO, get her back to the hybrid OR, swap out the big sheath TAVR without mechanical circulatory support. It was pretty obvious that she was not ready to be liberated from ECMO. And so we actually did option 3, which is recovered her for about 2 days, confirmed that she's got neurologic function, which fortunately she did. And then we did the ECMO on TAVR, double stuck the left leg, put a second big sheath up and did the ECMO on TAVR. For the TAVR operators in the room, this was really kind of an interesting insight for me. This was my first time doing TAVR on ECMO in this capacity, and the BAV balloon just shot into the ventricle. As soon as we went up with a BAV balloon, the force of retrograde flow just shot everything into the ventricle. So we actually deployed the valve with a map of about 20 or 30 and 0 pulsatility to ensure that it stays just right there. Everything looks good. Fortunately, this patient had a great recovery, total functional recovery, alive and well over a year later, maybe a year and a half now. And so the takeaway messages here are, in severe AS with cardiogenic shock, start with objective data, if at all possible, hemodynamics, other explanations for the shock state. In patients where you sort of decide that you're going to wait this out, TAVR may be deferred with BAV and Impella support versus Impella backup. I think if you're planning on using it, just use it as opposed to backing up. My personal feeling about this. And some of the candidates for that are highlighted in blue. In patients who require urgent or emergent TAVR, proceed with MCS. Our choice is usually via ECMO, sometimes LAFA tandem, and consideration for biatrial drainage. And support that way. Thanks so much.
One question. Why you waited next day to do the TAVR? Why you didn't do it once? Sorry?
They talked about the neurological recovery.
She had a fair amount of chest compressions. We wanted to make sure that anything that's going to recover is actually going to recover before we proceeded.
It all depends on the local expertise, of course, in Houston here. For this, I think if there is one percutaneous circulatory support device made for critical aortic stenosis, it's tandem heart. You don't need biventricular support. You take out the left atrial and oxygen. You don't even need an oxygenator. Immediately, the hemodynamics change. Now, we've got a large experience with those group of patients. And of course, you're right. Whenever you're flowing retrograde, when you're doing the tandem, you have to be very careful. The balloon does go into the ventricle. So typically, we clamp. We tell our perfusionists to clamp at the time just when you're doing rapid pacing. But we've never had to do a biventricular drainage, or we had to do anything else. You can do a tandem, stabilize the whole thing, and then you go in. Because you don't want to do a BAV one time, expose the patient to all the risks of BAV, and yet not achieve the complete therapy. So our default, unless in a case like yours, where there was a neurological issue, we would like to do all of that at the same time.
Agreed. Yeah, we deferred the BAV after we cleared up the left main and everything, and did it all in one setting 2 days later. Tim.
Yeah.
Fantastic case, but some procedural questions may be helpful for the audience. What about antithrombotics in that? Because talk about the lines and Dr. Carr's point about what system you'd use and bleeding, and the thing was clotting in front of your eyes. So how'd you manage that? What did you use?
Yeah, I mean, we had pretty high procedural anticoagulation with heparin. The issue of DAP non-compliance or non-adherence came to the fore later on. So, in the end, I don't think it was all that much of a mystery why it clotted off. We were a little bit reluctant to use GPIs or cangrelor because we were having a fair amount of bleeding. And actually, in the interest of brevity, I took out the adventures in antegrade perfusion because of the hematoma and so forth. But normally we would intensify this in our lab, usually cangrelor.
Got it.
Sandeep, VT trial, what percentage of the patients was the cardiogenic shock from coronary disease? Did they separate it out?
I don't think so. It was actually a relatively low percentage of patients who had obstructive coronary artery disease in the TVT data. It was quite low, but I don't know that they separated out.
Last comment?
What I would be interested in so Greg's case, But the thing I'm always concerned about is the co-occurrence of aortic stenosis in VA ECMO patient, which might lead to aortic root thrombus formation. And I would be interested in how you managed it. Did you have a very particular protocol for TEE to scan for that, or just high anti-thrombotic therapy?
Yeah, I mean, it's a great question, and there was a paper, I think in Perfusion 2018, that showed that root thrombosis and LV thrombosis, not in the AS patients specifically, was surprisingly high, and usually ended very poorly, not surprisingly. So, we just maintained very high procedural anticoagulation and had daily TTEs. Fortunately, she had relatively good windows there, and then. One of the issues we said, maybe we can hasten this by just doing the balloon aortic valvuloplasty. On the other hand, if we generate quite a bit of AI, this is, we're just shooting ourselves in the foot.
If it works, it works. If it doesn't,
right.
Bend over and kiss yourself goodbye.
We'll end there.
Okay. I